Good morning, everyone. It's 8:32, so I think we'll go ahead and get started because we have a very busy agenda this morning. First of all, welcome. My name is Erika Amarante. For those of you that don't know me, I'm a partner here at Wiggin and Dana in the Medical Malpractice Defense Group. And we are really thrilled to welcome you to our 2022 Grand Rounds presentation and event. Many of you may know that we've done these in years past, and it's always been in person. And one of the things I like best is just having that networking and exchange of ideas. But with COVID, we have not been able to get together in person for many years. So we finally decided to try this webinar format. This is our first time doing this as a webinar, and there's pluses and minuses to that. One of the pluses, of course, is that nobody has to travel in today's unexpected snowstorm that we're getting here in Connecticut. And another plus is that we're able to entice speakers from outside the state of Connecticut to come and share their wisdom with us. And so our first speaker this morning is going to be someone from the Midwest who I'm just thrilled to introduce. Maggie Neustadt is the Vice President of Risk and Claims Management at St. Luke's Health System in Kansas City, Missouri. And I first encountered Maggie through DRI, the Medical Liability and Healthcare Law seminar, where she presented back in 2018 on these uncomfortable disclosure conversations that are so important for healthcare providers to consider. And it's a topic that I've given a lot of thought to myself. And I'm really very excited to hear Maggie's perspective and learn a little bit from her experiences as well. So without further ado, I'm going to introduce Maggie. Thank you so much for joining us.
Sure. Happy to speak about this. It's a subject that I'm passionate about. I love sharing it. Successes, trials, tribulations. So I'm happy to spend some time talking with you all about it this morning. I'm going to set a timer here so I don't take too much time. So as Erika said, my name is Maggie Neustadt. I'm an attorney in Kansas City, Missouri. Spent 10 years in private practice representing doctors, hospitals, healthcare providers when they were involved in professional liability litigation. And then 11 years ago, I moved in-house with a health system in Kansas City, St. Luke's, to manage their claims internally. And the risk management functions of the health system kept growing and growing, and eventually I straddled both worlds. So I currently head up our clinical risk management and patient safety program for the health system. And then I also manage the claims, the general liability and healthcare professional liability claims for our captive. We have a Cayman domiciled captive, about 7 years old, and so do a lot of claims management and risk management, which gives me a unique perspective on the practical and reality situations that flow from these disclosure conversations. So next slide. What we're going to talk about this morning is really just setting the stage for why we even do disclosure, right? So part of this flows from the culture of healthcare transparency that has really grown up in the last, I'd say, 10 years. And then we're going to talk really about what a communication resolution program is and why it's more than just saying sorry. So next slide. So first, I know in looking at in terms of the audience, we've got some risk financing folks, we've got some clinical folks, we've got some outside defense attorneys, we've got all kinds of different people in private practice and in in-house settings. So everybody's going to bring to this presentation a little bit different perspective. And this is not going to be a one-size-fits-all discussion, but some of these concepts are going to span across this entire continuum of folks that we have here. And there are these concepts that have emerged in really out of patients' rights and value-based purchasing, if that's a term that you're familiar with, that the insurers who are paying for healthcare for their insureds want to make sure that the care that's being provided is patient-centered and safe. Those are words that they seem kind of squishy and a little touchy-feely, and they are. But as consumers of healthcare, which we all are at some level, whether you have a kiddo that you take to a pediatrician or an emergency room, or aging parents that you're helping take care of, or you yourself have chronic or acute care needs, these are concepts that matter to all of us because we all not only working in healthcare, but we also consume healthcare. So this patient-centeredness, which really means the patient is at the center, really the reason that healthcare exists. It's not to make money, although there are profit and for-profit organizations. It really should be about the patient at the center. And then because of that, the payers have said, we also want to make sure it's safe. You know, you hear all these articles and, you know, there's lots of sensationalizing in the media about how, you know, these horrible catastrophic things that happen. And we all know, being in the industry, that they do happen. And we'll talk about some of those that happen. So the industry wants to make sure that the services that they're paying for are safe, and that the organizations that they're paying and sending their insureds to have processes in place to make sure that they are improving patient safety. Now, we all know that you are never going to reduce every risk in healthcare. One of my surgeon colleagues likes to tell me that every time they operate on a patient, they are harming a patient, because they are cutting their tissue, they are cutting them open. But it's a risk-benefit analysis, right? Is that cutting that patient open, the benefit of doing that outweighs the risk of making that incision. And so, but patients don't seem to understand that. Patients don't understand that bad things can happen even in best of care scenarios. And so I know we as lawyers and as healthcare administrators and risk managers spend a lot of time trying to explain why I know this looks like something wrong happened, but it didn't. And this is either just an expected complication or an unpreventable complication. And so this patient safety movement has been really important, but it does create a little bit more challenges for our job. So next slide. But the one that really drives a lot of what we see happening in healthcare right now is this concept of patient experience. And you know, you see it in every industry, right? You see it in hospitality, you see it in marketing. And it's all about the experience and making sure that customer service is part of the healthcare delivery model. And they call that patient experience. It's just it's the healthcare term for customer service. And so there are organizations, and it's primarily called HCAPs for hospitals. But then there's also home health caps, and then hospice caps, because I know we've got some home health and hospice folks on the call. And those are the surveys that if you've ever been a patient, you will get bombarded with emails or phone calls asking you to fill out a survey. And the reason why that matters is because that is tied to our payment by Medicare, by Medicaid, and by private insurers. A lot of private health insurers will insist that you have certain HCAP scores or patient experience scores if they're going to continue to keep you on their plan. And so that drives a lot of it. And some of the HCAP's questions will ask questions for the hospital setting, for instance. How restful was your stay? Well, we're not a spa. We are we're healthcare providers, but that is one of the things that we're being graded on. One of the questions that the HCAPs used to ask was, how well was your pain managed? And to some certain extent, they do still ask those questions. And part of that, chasing these HCAP scores, there's the strain of thought that thinks that that's what contributed some to the opioid crisis. That grading us on how pain was controlled meant that we were incentivized to provide more pain medication to patients so that they would give us good scores there, which then in turn created this downward cycle of patients who needed more and more narcotics. What we're doing now in healthcare is tapering away from that and really saying, managing patients' expectations at the beginning, saying you are going to be in pain after your procedure. You need to understand that you're going to have pain. This is not going to be a pain-free process, but we will work with you to develop a safe program for managing the pain. But again, because you know they're going to get that question afterwards about how was your pain controlled. So then the other ones that we're really familiar with are these US News and World Report rankings. And then what's called Leapfrog, which is something that a lot of you may not be familiar with. It's a random name, don't know why it's called that. But these are the two good housekeeping seal of approvals that hospitals and healthcare organizations really chase. And again, it's tied to pay for performance and this value-based purchasing. And it's publicly reported, right? Everybody wants to be able to have these logos on their websites, these logos on their billboards in their community. And so part of what you see here at the bottom of the slide is that Leapfrog and US News are using these patient experience and patient safety rankings into their ultimate scores. So they are driving us to pursue patient safety, patient experience by virtue of adding that in as a pretty heavily weighted factor in our rankings that we're striving for. So on the next slide, I want to talk a little bit more about HCAHPS, or about the Leapfrog up close. So it is, again, this pay for performance. And so Leapfrog, which if you go out and you Google it, it's a public website. It says on there, their slogan, some hospitals may be better for you than others. And for those of you who work in hospitals, you don't want to be on that list with a poor grade. And so here's an example. I tried to pick some place where I wouldn't get anybody on the call. I didn't want to embarrass anybody, but so I typed in Honolulu. And here's what it looks like. You type in your city, you can type in your hospital, and it gives you your grades. And obviously it's A through F, just like your academic grading. And you obviously want to be an A. And they grade you on, next slide, on several different categories of performance. And you can see infections, problems with surgery, safety problems, practices to prevent errors. And there's a dashboard there. But on this one, this is what I wanted to point out, is what do safer hospitals do? What it talks about is that they are aware, the leadership is aware of patient safety problems, that they work with staff to fix them, and then they share those efforts with the larger community. So this is what's going to tie back to this transparency, is that we are being graded on how transparent we are with our community about the mistakes that happen in our facilities, which again is really, really new. And then you can see here in the circle, it says hospitals can earn an additional, big bonus for having leadership structures that increase awareness of patient safety issues and hold people accountable for improvements. So what does that look like? How do they get this information? Well, last week I filled out our Leapfrog survey from the patient safety and risk management perspective. And they sent me a list of 9 questions, very elaborate, on how we manage never events. And those of you, who are cringing with me at the concept of something being called a never event, a horrible terminology, right? I mean, again, I said a lot of times there are certain things that will happen, even in the, unfortunate things that will happen, even in the midst of the best, safest care. But calling them never events basically sets it up as a negligence per se type of a claim, saying this should never happen. And these regulatory agencies are calling them never events. So if you have a patient who fell and was injured, that should be strict liability or negligence per se. So that's my little, soapbox about that terminology. We call them sentinel events or serious adverse events, but we don't call them never events. But they specifically ask us to articulate and explain our answers to these questions. Do you have a verbal apology and explanation process after a never event? Do you write off patients' costs for these never events? Does your review of a never event involve the patient or the family? And then do you share those corrective actions with the patient and family? And there are 5 other questions that they ask that really are corollaries to this. But you can see where it's not just organizations that are deciding, we really should do this because it fits with our philosophical and mission-driven culture. Organizations that aren't doing disclosure are going to be pushed there because the payers are going to push them there. So if you're not already doing it and your organizations aren't already doing it, know that it's coming. And it's better to get on board sooner than later, because there were, as an organization like mine that's got a really mature disclosure program, there was still a question they asked us about how we audit adverse events to make sure that we checked all these boxes. And that was an opportunity for us that we don't have that mechanism set up yet. So it's a good thing as a consumer of healthcare. It is a good thing as a healthcare provider. It is complicated, it is time consuming, and it is very uncomfortable in certain circumstances, but this is definitely the direction that we're going. And I guess, Erika, what I didn't say is if there are questions in the chat that come up that are relevant and you want to interrupt me, please feel free to do that. Next slide, please. Okay. So really, communication and resolution or disclosure is not new. The University of Michigan is the mother of this whole process. And in 2004, they really stood up the first program. And it was revolutionary at the time. And we all thought, oh my gosh, they're crazy. There's no way that they can do this. This is just going to put a target on their back. But what they found in this article from USA Today that was 6 years later says that your malpractice suits drop when you admit mistakes and you apologize. And if you go to the next slide, it's sort of defies logic. And when I talk to non-lawyers and non-clinical folks about this process, it just blows their mind. Why would you ever admit that you did something wrong? That's just an invitation to be sued. But when you talk to them a little bit more about the why and what's in it, which is what we'll talk about in a few slides here, what's in it for providers, what's in it for patients, they understand. But I mean, at first, it's just that old deny and defend model was sort of our comfort zone, and we've had to push beyond that. So another really good organization that grew up out of this process is the Collaborative for Accountability Improvement, and it's where basically the 4 founders of the disclosure and accountability movement got together and created this resource of helping to drive education, helping to drive policy, helping to work with states that are creating mandatory disclosure rules. So this is another good resource. And the next slide, please. And then in, oh my gosh, I can't remember what year, but AHRQ, which is a government-funded branch, it's the Agency for Healthcare Research and Quality, put together what they call the Candor Toolkit, and it's communication and optimal resolution. And then this is when things really took off, is they identified specific tools for healthcare organizations to use, very straightforward, easy to implement, to make sure that when you have an event, a never event, a serious safety event, or a sentinel event, that there is a process for making sure that that is communicated to the family. And this is just a quick shot of what Candor looks like. And I'll have some of these resources at the end for you. So next slide, please. And then when I did a little bit of digging about some of your local programs, and I think there's somebody from Yale New Haven on the call, a couple folks actually, you guys have a pretty robust program, and it's got a catchy name. It's called CLEAR, which is Communication Leads to Early Resolution. And so you can see this is available on their website, that they are advertising that this is something that we do. I Google, my website doesn't, that we don't advertise that this is something that we do. And so that's one of the things that I'll take back to my organization to say, why not? Why wouldn't we put this out here? And I'll be curious to talk to the Yale New Haven folks offline to say how has this helped them? How has this backfired potentially or created some challenges in the litigation setting if there wasn't a disclosure that was done or a family reaches out proactively for a disclosure. So, but it is a differentiator for your organization when you meet with underwriters. I think they will ask what your philosophy is on that. I know there's some underwriters on the call, so I'd be curious about your perspectives. And then it's a marketing tool, right? To say that we are an organization that is transparent with you. I mean, we're moving towards transparency with pricing, right? We now have to post our prices online. And so the more transparent we can be about all of our processes, the better. So kudos to Yale New Haven. Next slide, please. Okay. So that's the background, and that's how we got here. So why would we do this? Well, obviously there are benefits to the patient, and the benefits to the patient really include getting answers versus what they perceive as a cover-up. When we don't have information, when something goes wrong and we don't have information, or even if something doesn't go wrong, for those of you who have kids, your kid doesn't pick up a phone call, or you can't get them to respond to a text message, or your significant other is driving in a snowstorm and doesn't make it or is late for a meeting, and we go from 0 to crazy in 60 seconds when we don't have information. Our minds are programmed to fill in gaps with suspicion, and sometimes that suspicion gets very negative. And same thing with our patients. We find that their perception after an adverse event is the worst case scenario. And so when we can get in there and provide them with answers, a lot of times that eliminates all of that sting, it eliminates all of that anxiety, and provides them with answers. There is literature out there that says that I think upwards of 70% of patients go seek out legal counsel after an adverse event because they want answers. they just want answers that they felt like they never got from the organization. And of course, then by the time a lawyer gets a hold of it, they see a potential payday, and then we're off to the races. The other thing that this offers to patients is empathy and sympathy. And again, these are squishy concepts, right? They don't teach, now I've been out of law school for 20 years, but they don't teach empathy and sympathy in law school. So, and they are doing a better job about teaching it in the clinical settings, in nursing and in physicians and, the allied health professionals. They are teaching more empathy and sympathy. But it is just not something that is necessarily inherent to the healthcare profession. And it matters to patients. And I will tell you, you hear it over and over again, is that all they wanted was someone to acknowledge that this was a difficult situation for them and to show some empathy and apologize. And here's an example from a case that I had in 2016. I've had two really catastrophic events in the 11 years that I've been with my organization, and this was one of them, and we'll talk about the other one here in a few slides. This was a completely preventable medication error that resulted in the death of a 70-year-old woman. Now, the 70-year-old woman had already had multiple outside of the hospital cardiac arrests, and was not likely to survive that hospitalization. The mortality for cardiac arrest when it occurs outside of the hospital is greater than 98%. And she had each time that you have an additional cardiac arrest, it goes higher and higher. I mean, she was not going to survive her cardiac events. That being said, we gave her a medication that probably hastened her death. And it didn't need to happen. It was a communication error. It was a misunderstanding, and it was 100% preventable. It was a situation because this patient was likely to die that we didn't discover until the day after the patient had died. And this daughter who sent this email here just assumed that her mother, who'd had a long cardiac history, just finally succumbed to her heart attack, her heart issues. And the following day, when the nurse said, that physician asked me to give an order that I really wasn't very comfortable with, and we dug into it, we realized that we had given this patient a 5 times overdose of a very dangerous medication. And at that point, you think, well, she was going to die anyway. Do we need to disclose this? But we felt really strongly that we needed to reach out. We needed to tell the daughter. And so we reached out through her cardiologist, the long-term cardiologist. We asked him to reach out rather than just somebody from risk for legal cold calling. And he reached out and left her a message. She didn't call back. He left another message another day later. And she finally sent a message back through our portal saying, listen, I appreciate everything that you've done for my mother over the years, and all the care that you provided to her. And we are grieving, and I appreciate your phone calls. And so now what do we do? Now she's shot us down. And, at some point you could have said, okay, well, we tried, right? We tried to disclose it. She wasn't interested. At this point, all we're going to be doing is just opening wounds for her, but it didn't matter. And so at that point, then my former boss, who's Bonnie Johnson, knew her socially from the industry. And so she reached out to her and said, I know the doctor's been trying to call you, but we actually have something that we need to share with you about your mother's care. And then she made the introduction where then I began talking with this family and explaining to them what happened. And the first question that they asked me at our first conversation was, would that have caused her any pain? And the answer was, it very well might have. It might have. When you get an overdose of medication, it can burn, it can be very uncomfortable. And you have to be prepared to answer those kinds of questions. So when I talked with her, I said, I certainly understand this is information you were not expecting to get. Take your time to process it. If you want to talk with a lawyer, I would certainly encourage you to do that. That won't change the dynamic of how I interface with you. And then about 2 weeks later, I did get a phone call from a lawyer who I know and work with frequently. And he said, first of all, this is going to be a cap case. We have a wrongful death cap in the state of Missouri. And he said, we're not going to try to profit from this, but they do feel like they are entitled to some compensation. And I said, absolutely. And we cut him a check for the cap. And we were done with it in about 60 days. In Missouri, you have to have a hearing for wrongful death settlements. And so had to go to court which I usually assign to outside counsel, but in this case, I felt really strongly that I needed to do it myself. I wanted to be there to do that, to show that accountability for the organization. And then after the hearing, the family said, could we sit down with you for a few minutes? And we want to know, what have you done to make sure this won't happen again? Because I had told them that's part of our process. And so we did. We found a witness prep room at the courthouse, and we spent 30 minutes just talking about what we had done and what this had meant to them, and me listening to what this meant to them and the loss that they had sustained. And then a few days later, she sends this email to my boss, and she says, while the past few months have been difficult, I want to appreciate your kind remarks, and I want to let you know that we took some comfort from Maggie's genuine expression of heartfelt sorrow on behalf of the hospital. Now, I'm not sharing this with you to say, yay me, look what I did. It's to share with you that this really matters to patients and families, that these types of human interactions, because hospitals and healthcare organizations, they're boxes, right? I mean, they're companies, and we are, as risk managers, oftentimes the face of that company. And it is incredibly important that we be prepared to show empathy and sympathy in these scenarios. And in fact, when I interview new staff, new risk managers, and I know we've got a lot of risk management folks on the phone, one of the things that I ask them is, how would you describe your ability to be empathetic? Because that is a really important skill set in a risk management professional. So this is what's in it for the patient. So next slide. And what else do you get? Well, it really restores trust in the organization. So let's say, so obviously this daughter that I had these conversations with, she is also a consumer of healthcare. I want her to feel like she can continue to get her healthcare with our organization, and that she doesn't have to sever ties with us because of what happened. So that restoring trust in the provider or the organization. And one of the other scenarios we're going to talk about next is a patient who was in the middle of a cancer treatment. You would hate to think that when something happens, an adverse event happens for someone who's in the middle of a chronic or a long-term health issue, that they feel like they had to switch, right? That I can't trust you, and now I need to go find a new healthcare provider who can pick me up in the middle of my chronic medical management. And so it makes the patient understand that they can trust us, that we did make a mistake. We're telling you about it. Here's why you can trust us, why you know it won't happen again, and that we're going to be transparent with you. Obviously, it's also the non-adversarial compared to the litigation process. And then it gives you the chance to address financial barriers and get creative with compensation. So next slide, I want to talk a little bit about that creative compensation. So obviously there's compensatory types of compensation, non-compensatory. So, one of the things Leapfrog asks is, do you write off their medical bills? That's an easy go-to, is to write off bills if you can, right? So if your physicians are employed by your organization and you have the ability to write off their bills, you can do that. But if you have independent physicians involved, you don't have any control there. Or if there are services from ancillary providers that you don't have access to. But just, taking some of that financial strain off of patients can be a huge de-escalator in these situations. And then arranging follow-up for patients or no-cost follow-up. So in a scenario where you have a patient that has an unsterile surgical instrument that's used, you would say, we're going to have an infectious disease doctor come by and see you at no cost to you. They're going to do some baseline testing, and then we want you to follow up with them in 6 months to do some additional testing, again, at no charge to you. And that goes a long way to eliminating some of that anxiety that patients have about it. You can advance hotel costs, reimburse travel expenses, advancing money for childcare or funerals in really challenging situations. And then there's the non-compensatory. What kind of things just reduced families' angst? Could you, right now, we've had really restricted visitation. In certain circumstances, we've waived those visitation rules just as a gesture of what can we do to help in this scenario. So one of the creative compensation situations that I told you I've had 2 serious adverse events. This one was the second one. And what you're looking at right there is a pump, a chemotherapy pump. And it's a portable pump that you come in, you get programmed to run your chemotherapy, and then you can go home and do your therapy at home. And this pump was programmed with a really, really potent chemotherapy agent. And it was supposed to be programmed for 2 milliliters per hour over 46 hours, right? So she was going to get a really slow dose of this medication over about 2 days. And what happened was that the individuals who programmed this pump inadvertently put it in for 46 mils over 2 hours. And so this very toxic medication was very rapidly infused into this patient. And at home, she says, gosh, my pump is alarming that it's empty already. And we said, well, that can't be right. And we're able to see them remotely. And we said, oh, Barb, you've got to come in. So she comes into the emergency department. The oncologist meets her down there and says, you have been overdosed, significantly overdosed, and it can be lethal. And there just so happens to be an antidote medication that you can give, because apparently this is not an uncommon complication, but we didn't have it in Kansas City. It had to be flown in from Philadelphia. And so we chartered a jet to have it flown in from Philadelphia. But the oncologist told Barb, he said, Barb, you need to be admitted for the next 3 weeks. You are going to be as sick as you have ever been. And, and here's what happened. We made this mistake. Now, did Barb have options at that point to go anywhere else? I mean, to say, you know what, forget you, I'm going to another. She didn't have a choice. It was basically, what choice do I have but to trust you guys to fix this for me? And so I met Barb that day in the emergency department. And I said, I apologize. I mean, an apology is not going to cover what happened here, but I want to let you know that we are going to do everything we can to take care of you. And she said, just fix what you did wrong. Just fix me. And so, so Barb was admitted to the hospital. I visited with Barb every day or every other day, talked frequently with Barb's brother who lived out of town. Barb had no family in town, and Barb's only family was her dog. She had a dog that she would show, a show dog. And she was very concerned about what was going to happen with her dog while she was gone. And so I said, we can kennel the dog. What would it take to get the dog kenneled? And so we arranged to get the dog kenneled. We paid for that. And then after about a week, when Barb recovered, she said, I'm really missing my dog. And so we coordinated with her treatment team to say, could we get the dog brought up here so that she could have a visit? And that's the picture that you see there on the right. And that meant everything to Barb. I mean, to be able to see her, her best friend, her child, it was so important to her, and it meant so much to their family. It wasn't that, it was logistically a little challenging, but we almost killed this woman. And it seemed like the least that we could do. And over the course of that time, Barb and her family really appreciated what we did. And of course, we compensated Barb with a financial settlement. But Barb ended up dying from her cancer, not because of this event, but she survived and went on to die from her cancer. And her family invited me to her funeral. And I went, and it was profound. These relationships and this sort of empathy. Now, I'm not suggesting, and I don't do this with every patient and every family, but this was huge. And I felt personally responsible as a representative of the organization that I work with. I felt like we owed it to this family to do what we could to make it right. And what's helpful is, obviously the healthcare providers who were involved were devastated. They all, wanted to turn in their resignation. They thought, I picked the wrong profession. And those of you who work with physicians representing them when they get sued, this is personally and morally very devastating to them. And part of what this process allows us to do is to say, you made a mistake, or the process let you down. We had a triple check, double check process that failed. And it's the organization's responsibility to make sure that we set you up for success instead of setting you up for failure. This is not a personal failing. And sometimes, of course, they are. And you have to be candid with them about those. But it's to say, you are a good healthcare provider. You go back to doing what you do. Take your time to grieve and get counseling and do what you need to do. But you go back to taking care of healthcare providers, and you let me and my team take care of this, because that's what we do. And it's a privilege to be able to do that for the healthcare professionals that we work with, because I know they show up every day working their rear ends off to take good care of patients. And we all make mistakes. It's just the mistakes that you and I make might be leaving a zero off on a loss run, or forgetting to update a regulatory report, or needing to get an extension because you've missed an answer deadline. we don't have necessarily matters of life and death in our hands. And so we have a lot more grace when it comes to making mistakes. And I think it's really important that we support our healthcare professionals that way.
Maggie, if I can interject there, actually, we do have a couple of questions. And first is really just a comment from one of the participants that this slide in particular shows the recognition that there's a human behind the adverse event. So these stories are really very impactful. Thank you very much, Maggie. There's also a question though, regarding the Joint Commission standard that requires disclosure for sentinel events and how that intersects with Leapfrog, which is a best practice, and whether or not you've ever encountered a situation where a professional liability carrier or excess insurer is not in agreement with a hospital's decision to do a disclosure when it's not required, for instance, and would that compromise the access to insurance coverage if it's essentially an admission against interest, for instance? And bear in mind, I know you mentioned that your state has caps. We don't in Connecticut. So when you're easily able to know what the value is for that medication error, for instance, we don't necessarily have value set like that. So any thoughts on that scenario?
Yeah. So yeah, first of all, lots of really good questions. So let me tackle the Leapfrog versus Joint Commission accreditation. So Joint Commission, and I call them all the good housekeeping seal of approval. I mean, Joint Commission is our accrediting agency. And so that is really not optional. You've got to have it. You either have to have DNV, which is another accrediting body, or, there are a couple of other organizations, but you've got to have Joint Commission accreditation for the most part in a hospital setting. And Joint Commission does require that. I don't know that they're necessarily, the Leapfrog is something that you're just chasing from marketing perspective. I don't know that it drives as much change as Joint Commission does. So I would certainly defer more to the Joint Commission. It is not, it's a little bit more straightforward, and you'll be graded on those. Obviously, when you have your triennial surveys with Joint Commission, they'll want to make sure you have that checkbox. Leapfrog, it's not a matter of getting your certification. It's just, where do you get it? Where does your grade come in? It is challenging sometimes with the excess insurance carriers. And so I'm glad to see that there are some on the phone. The most challenging situation this comes up in is where you have a hospital error that also involves a private practice physician, and there are two different buckets of insurance there. So from a hospital perspective, and I've had this happen several times in obstetrical cases, where we feel very strongly that we need to disclose to a family something that happened. And we will reach out to the obstetrician, who then reaches out to their malpractice carrier, and they say, well, what are you thinking? What are you doing? What are you going to say? And we've had this happen in not just in obstetrics, but lots of different departments. Emergency medicine, because in my health system, most of our physicians are employed, with the exceptions of emergency medicine, some GI, and obstetrics. So when you have those independent physician scenarios with a separate bucket of insurance, it does get challenging. What the position and how we've handled that is to say, we feel really strongly we need to discuss this with the patient. It would be the best if we could do it together so we can answer all of their questions at once. But that's certainly your prerogative. And if your insurer is not comfortable with that, we understand, but we're going to move forward anyway. And you need to understand that there are going to be questions that they're going to ask that we won't be able to answer on your behalf. And you don't want us to answer on your behalf. That wouldn't be appropriate. What we typically ask then is maybe would that carrier assign counsel to the independent physician, and we can have a discussion with that counsel to explain what this process is, why we do this. But I find that more and more that the healthcare professional liability insurers understand this process. And in fact, some of them even have full-time staff who are dedicated to facilitating these type of disclosure conversations. So that can be complicated. But I do think most, and I'd be curious, and I don't know if there's an industry standard in the excess insurance world about whether or not they're on board with that. I know when we meet with underwriters, it's something they ask us and they are very interested in. So I've not had a scenario where somebody pushed back on that. They trust our judgment on when to do that. And was there one more question in there? Oh, the coverage. I would make sure, I think those are important discussions to have with your underwriters when you're meeting with them, is to say disclosure is really important to us. And we want to make sure that this is something we can continue to do. what's your philosophy about that? I think that's a really important discussion to have to make sure there is a good shared mental model about how you're going to handle these scenarios so that it won't impact your coverage. Okay, so it says, in the states that have no caps. It is complicated in the states where there's no cap. So I practice in Kansas and I practice in Missouri. Kansas doesn't have a cap. It really is just a matter of then resolving, do you mediate? Do you try to figure out what are your economic damages? What are your non-economic damages? Are there any considerations to be made for punitive damages? So it is harder to calculate what a case is going to be worth, obviously, in a case that doesn't have caps. But I think that goes back to making sure that you have those discussions with your carrier about it. I would not, I guess at that point it becomes a business decision, and talking with your leadership to say, we really would like to disclose this scenario, but if it's going to nullify some of our insurance coverage, then it'll need to be a business decision. And is the organization willing to not disclose to preserve the insurance coverage? Or do we disclose and take the risk that this may be something that we pay for out of operations?
Another question I have, Maggie, is just you mentioned the concept of giving answers versus a perceived cover-up. And in some of the scenarios that come to mind, I mean, the examples you've given are medication errors, so it's obvious and somewhat easier to investigate. But have you had situations where it takes some time to investigate what the underlying cause of the incident was, and that the patients and their family might get more testy or skeptical as time goes on? And is there a way to expedite that, or any advice you can give in those kinds of scenarios where it's not quite so cut and dry?
Yep, sure. No, absolutely. In fact, let's go to the next slide, because we may get there. Okay, so, and Erika, I'll answer that in a second here. So what's in it for you? Well, I mean, avoiding certain things. So from a risk financing perspective, we hate uncertainty, right? We want to know, if we can, and again, without caps, it's difficult to say, but if you can resolve claims early and you can control them rather than turning them over to the litigation process where there might be punitives and there may be all kinds of jurisdictional issues, it gives you a little bit more control over the management of your claims and suits. And then for the clinical folks, it avoids unproductive time. Your physicians that you work with, your organizations, those of you who are clinical, there is nothing worse than pulling a healthcare provider out of, especially what we've been going through in the last 2 years, to answer discovery or give depositions. I mean, it is that unproductive time is devastating. And so it helps you avoid those. Next slide. Sorry, next slide, please. Okay, so I'll skip to the next one. I mean, these slides will be available if you want them, but it is good for resolving things quicker. So next slide. Okay. So in short, even though this sounds like a really good claims management program, it really isn't. I mean, it has claims management benefits, but it really is on emphasizing the performance improvement, not just managing a risk in the moment, but really creating a safer process overall. So I think the next slide is where we get in some of what we'll talk about. Okay, so let's talk about some of the prep work, which Erika gets to your questions. I'm trying to be mindful of my time here. So things to think about before you even have that first discussion is who's going to do it. Who will be doing your disclosure with you? And I guess one of the questions that you guys have pointed out is running it by your excess carrier. Do you need to get their permission before you do these? Do they expect you to make sure that you've let them know that you're going to be having this discussion? So I guess that would be another thing to factor in here. But not all physicians and healthcare providers or administrators are created equally when it comes to doing the disclosure. And one of my risk management mentors had a scenario where a physician, an anesthesiologist, did a esophageal intubation. So the tube was not in the patient's air pipe, it was in their esophagus. And when he came out and told the family, and he'd been very belligerent and difficult in this situation, he came out and he told the family, he said, "I can't believe this happened to me," to the family of a mother who had just died. And that's not the right way to handle disclosure, to make it about yourself. It's really about disclosing information. So some people won't do a nice job. So think about who's going to do your disclosure. When do you do it? And Erika, that gets a little bit to your question. And I think on the next slide, we'll talk about, it's important to do it right after, as close to the time that you find out about it, but you won't have any information yet. So sometimes the first discussion that I'm ever having with a patient is to say, I understand that this has happened. For instance, maybe it's a wrong site. Well, I'm trying to think of something that's a little more subtle. A patient where let's say there's an unexpected complication after a surgical procedure, and you'll say, we're not sure what happened. All we know is that we would not have expected this outcome in this scenario. And we're not sure what happened, but we need you to know that this is not what we would have expected, and we're going to be looking into it. So all you can tell them is that what we know right now is that your loved one came out of surgery, and for whatever reason, we were unable to take them off of bypass. We did the intraoperative bypass. Something happened in the case. We weren't able to take them off of bypass, and they expired. We don't know why that happened yet, but we want to let you know that, I'm the patient safety liaison. Here is here's the physician, and here is my quality partner. We are going to be looking into this, and we will be getting some answers because we want to know just as much as you want to know. And we will be sharing with you everything that we find out. So it's really important in that first disclosure meeting to say this is going to be an ongoing process. This first discussion, sometimes that first discussion is the easiest one because you don't have any dirty laundry to tell them yet, is all you can say is, and I sometimes tell them, it may be that everything went completely according to plan and this was just an unpreventable event. It may be that something did happen, and if I find out, I'm going to tell you because you are going to know what I know about this. But it is really important to manage their expectations so they understand it's an ongoing process. It is really important then, Erika, to your point, to designate a specific contact person for them to follow up with. Because again, if they don't hear anything, then what do they think? They think you're hiding things. They think that you're afraid to come back and communicate with them. So sometimes those conversations are them reaching out or you reaching out, just saying, hey, I'm following up. It's been 10 days since we talked last. Wanted to let you know I don't have any more information, but we've got this person who's looking at it, or we're waiting on this toxicology report, or we're waiting on the autopsy. So it is really important to make sure that you explain it's an ongoing process, that you don't, it's really about managing expectations and letting them know that it could be that you may not get a smoking gun. And then sometimes, the answer is we may never know what happened, but we will do everything in our power to try to find out and get you some answers. And then I do think it's really important to encourage the patients to talk to a lawyer. What you don't want to do is ever have somebody accuse you of trying to rush through a settlement or get a bargain basement deal and then say, well, they never told me I could talk to a lawyer. They told me I had to take this. They pressured me into taking it. And I will tell you, sometimes the lawyers getting involved actually helps because, lawyers understand things like statutes of limitation or limitations on liability or causation, right? Because again, patients sometimes think a bad thing happened, which means there was negligence, and they skip the whole causation process. And so having a lawyer who can help really explain the causation piece is important. Now, does that sometimes make the case worth a little bit more because they obviously want to take their cut? Yes, but in my experience, when we've done a disclosure and a lawyer gets involved, it has been to everybody's benefit. I have not seen it, with the exception of one case where it just, it wouldn't have mattered. The disclosure was important, and I think we got a lot of goodwill from the disclosure, but it still ended up being, a pretty significant settlement. So let's see, next slide. And then here's some resources. The Candor toolkit that was there that I told you about, and that collaborative. Rick Boothman, who some of you probably know, was the general counsel, or I think maybe it started as the outside counsel and moved into the general counsel at the University of Michigan, who was the leader in this. He is fantastic. And he has just recently moved over to doing some consulting with a company called Press Daney. He is a wonderful resource. There's not a scenario that he has not dealt with. And he would be a great resource if you're looking at setting up a program and you really want to get some insight on that. And then I'm certainly happy to answer questions or, bounce things off of you, bounce ideas off of if you've got questions. So And I don't know if there were any other questions. I think that was my last slide. So if there's any other questions, I'm a couple minutes over.
That's okay, because this has been so fantastic, Maggie. Thank you so much. I have one actually follow-up question, which is, when a lawyer is involved, how do you feel in your program about having them involved in the actual disclosure conversations? Or do you separate it and have the disclosure really just with the clinical folks, and then the lawyers get involved afterwards to talk the compensation?
Yeah, so there's a couple schools of thought about that. So generally, when you have that initial disclosure, there won't be a lawyer involved because they don't know that they need to have a lawyer yet. So that first conversation where you're setting the tone and you're creating a contact should help them feel like they don't have to go out and get a lawyer, because the organization is stepping up and taking care of what's going to happen. Some people just have lawyers in their back pocket, and so they will have them come in anyway. When I do a disclosure, I'm not telling them anything that is not going to come out in discovery. So you know, it really is just a matter of, I'm laying my cards out on the table. When you have that more comprehensive meeting, let me back up. First discussion with the patient is really just table setting. You have ongoing discussions, and at some point you will have a discussion that says, we've completed our review of this case, and we'd like to sit down with you and tell you what we found out. Sometimes people will bring their lawyer. And that's okay. I mean, again, because I think it's important sometimes that the lawyers hear it, because they understand the causation piece. They understand the damages piece. They understand they understand, and they can help be almost a moderator sometimes if the family's very emotional. And I think that can be helpful. So, and having the lawyers there, what I have found, honestly, and we're starting this process here in our program, is having several lawyers that we have worked with on these types of processes, where we tell a patient, you know what, we think it's important that you have legal representation. And so we've got several lawyers, and they say, well, we wouldn't even know who to call. And these are lawyers that will do it on an hourly basis instead of a contingency fee basis, where they say, you know, rather than me taking a percentage of your recovery, I'll just be paid by the hour, to help you with this process, which then maximizes the recovery again to the patient. So now we have a pretty tight knit professional collegial group of malpractice attorneys in Kansas City. I don't know that you guys have that. So again, some of it's really going to depend on the relationships that you have with your plaintiff's bar in your jurisdictions.
Right, and it does vary. I mean, there are certainly some attorneys that you can deal with these kinds of cases with, and others where it just automatically becomes an all-out unreasonable demand as soon as you disclose something. But thank you. We do have one more question, which is whether you would, how would you deal with the situation where there's a known complication of a procedure that materializes in terms of disclosure? Is that something you disclose and apologize for? And especially if it's something that maybe is on the informed consent, but doesn't happen that often. Is that in your program as a disclosure or not?
No, so that wouldn't be. Now, what, you know, if there's an unexpected complication, let's say you have a post-op infection that somebody develops, and probably a post-op infection is probably the best one, or a post-op need to return to the OR because of some complication. Again, that's where, from a risk management perspective, it's really important that your providers have a good, robust, informed consent discussion. And then the physician would usually take the first stab at saying, you know, I understand you're frustrated because you've developed this infection or this MRSA infection or this complication, but remember, we talked about this beforehand, that there was a risk of these things occurring after the procedure. And that's not something that you would apologize for, because it's not something that we did wrong. Now, then what would happen next is if the patient says, you know, I can't believe this happened, I'm calling a lawyer, that's when you would generally reach out to risk management, and we would manage that, again, just as an unmet expectations. And we'd say, help us, you know, sometimes we can come in and help explain things in a non-clinical way that the physician can't. And they say, well, we got this infection. We said, well, this is how this process works, and what information can I get you? And here's labs, and let's have, you know, an infectious disease doctor come by, or, you know, as somebody else come by and explain it. So a lot of times we're just doing our typical risk management type of process, but not a disclosure. Because it's really important to the healthcare providers. We can't run around apologizing for things they didn't do wrong, or else they will never participate in this with us, right? If they feel like we're going to throw them under the bus and pay money, because this is still data bank reportable, right? If we're paying it on behalf of a provider, if they feel like we're going to go out and pull the rug out from underneath them and apologize for every known complication and then pay for every known complication, they won't buy in. So it is really important that this really is only for cases where we think that there was an issue of liability, where we didn't meet the standard of care, or really there has to be a standard of care issue here for us to be able to do the disclosure. And then in a case where it is just a known complication or a non-negligent situation, it's really just explaining the process to them.
Great. Well, thank you so much, Maggie. I appreciate you spending all this time with us today, this morning as well. And I should have mentioned at the beginning that we are providing both Connecticut and New York CLE for this program. So at this time, I'm going to give you a CLE code for those that are looking for that CLE credit. The code is 3322. And I want to thank Maggie again for offering up your email address. And I'm sure if there are following questions, please feel free to reach out to me, to Kevin, Budge, my partner, or to Maggie. And we thank you again for participating in this.
And any of you attendees that attend FASHRM, the FASHRM annual conference in Boston, come find me. I'll be presenting at the conference, so hopefully I'll get to meet some of you there.
Great. Thank you very much. All right, so with that, we're going to move on to the second part of our program, which is a medical liability update. And this is the part that Kevin Budge, my partner here at Wiggin and Dana, and I do together. And we have not done this in a couple of years for this audience, mostly because the point is that we like to review the verdicts and settlements, particularly in Connecticut medical liability. There haven't been that many in the last few years with COVID, but 2021 was a little bit different, and we do like to make this as interactive as possible as well. So I will say, please put your comments in the chat, questions, but many of you in the audience will know more about some of the cases we're covering than we even do. But we like to just kind of summarize where things are going for Connecticut and open up a dialogue and discussion. And so with that, I'm going to turn it over to Kevin to start us off.
Thanks, Erika, and welcome everybody, and thank you for being here. Next slide, please. As Erika mentioned, we did this, and we did it. We have done this for about 7 or 8 years now, and we usually do it in person. And the intent is to create a dialogue, because as Erika mentioned, not only with some of the cases we might mention, but with some of the issues, those in the audience may have a particular knowledge that we don't have by either experience or some other means. So the intent here is really to have started a shared learning and a dialogue in the defense bar, much like the plaintiff's bar utilizes, because I think in the long run, it helps that continue with that dialogue and help each other, which will only help all of us in the long run, we think. As Erika mentioned, the pandemic years have been lean when it comes to the number of trials and verdicts that are out there. There are a number of them, and most of them more recent than the early ongoings of the pandemic. We're not intending to cover every single one of them, and I will tell you that there are probably more defense verdicts out there than there are plaintiffs' verdicts, and we're not really going to get into too much in depth with each of them. One, they're not necessarily always reported the same, so it's sort of difficult to glean a lot from them. And two, I just want to make note of it, just because we might highlight some plaintiffs' verdicts. It's really, the purpose of it really is only to highlight particular issues, or maybe it's something interesting about the case itself, or just as an FYI, and that's sort of the intent of these things. It's really not for anything other than that. And likely, some may have more knowledge about a particular verdict or know of one that we're not, highlighting. But that said, I'm going to move into what is the next slide, please. The first verdict that we just want to highlight, and this is a defense verdict. It's going to be actually the only one we're going to really talk about today. And I raised it because it was one of the first ones that occurred during the pandemic years, and it was one that factually isn't all that incredibly exciting, but it essentially was a patient who was admitted to a detox facility with alcohol withdrawal or withdrawal symptoms, and during the process of that admission fell, and according to the allegations, activated arthritis in her hip, which required subsequent hip replacement surgery. The defense to it was essentially that there were fall precautions in place at the time, and the causation defense was that she had already had a pre-existing far along arthritis, which had required or was going to require hip replacement surgery, and that the fall had really no impact on that. So basically an attack both on standard of care and also on causation. And it ended up being a defense verdict in Hartford in August of 2021, so last year, maybe 7 or 8 months ago, and one of a number that have now subsequently occurred, and we expect and hope that maybe will continue to occur, but only highlighted as, you know, things are sort of getting back to normal, and this was an in-person trial that went in that direction. Next slide. And this is just the verdict form, which, you know, we like to show these sometimes because there's something gratifying about actually seeing it in writing. You know, I'm sure the opposite is always true, but this is, you know, just for, I guess, just for whatever it's worth. Next slide, please. Now I want to touch on I believe it was the first in-person trial that occurred during the pandemic. This was actually a case of March versus USA. It was a case involving the VA hospital. It was a plaintiff against the government. So the case was actually a courtside case because they are courtside cases. And it was a US District Court, so a federal court case that proceeded before Judge Bolden in the United States District Court. And in this one, it was a 47-year-old veteran who had gone to the VA hospital for a hernia repair surgery. And it was alleged that during the course of that surgery, there was a cautery injury, a uterogenic, so it wasn't a through and through injury of the bowel, that subsequently after the surgery progressed to a full perforation of the bowel, which led to leaking of bowel contents into the abdomen, which led to a raging infection and required 2 surgeries that occurred to attempt to repair the bowel and bring it back to normal. Both those surgeries were unsuccessful, so the patient was referred to a different facility for an emergent surgery and ultimately was left with no abdominal muscles. The abdominal wall muscles were completely gone. There was something that, you know, we refer to as pot belly syndrome, but basically all the contents of the abdomen, you know, hang out in the skin because that's the only thing keeping them in, and it requires the use of a binder or an elastic belt to keep everything in. They sued, and after a 4-day trial before Judge Bolden found for the plaintiff, next slide, please, and awarded a substantial amount of money. The total amount is $9.4 million. It was $3.27 million for economic damages, a $5 million award for non-economic damages, and then also a $1.2 million award for loss of consortium. So there was a pretty lengthy, it was a decision, so it has, you know, some interesting information in it, but this is, you know, sort of getting to the heart of the matter or the punchline, so to speak. But it's a substantial number, especially from a judge, but, you know, it sort of puts a different perspective on maybe these types of cases on what values might be. And then next slide.
Speaking of a substantial number, especially from a judge. So our next highlight is a verdict or judgment that came down from a state court judge in the summer of 2021. And this was a case that I know many of you on the call today were more involved and know much more about this case than I even do. But it was tried before Judge Taylor in a remote proceeding. And then there was a judgment in the summer, which is now on appeal. And so one of the reasons to highlight it is just because I think together with March, which was also a judge decision because that was the VA hospital, here we have an entity of the state of Connecticut. You know, historically, you would think that you would do better with a judge than with a jury, but maybe that's not the case anymore. My understanding is that the demand was actually 73 million. So perhaps Judge Taylor did think that he was doing some favors, I'm not sure, but this is definitely on appeal. And if we can look at the next slide, just really quickly, I think the facts are fascinating in this case, and there were so many interesting appeal issues that will be raised as well. I mean, it had to do with an artificial insemination procedure with twin fetuses who were allegedly then exposed to CMV virus, which is a sexually transmitted but very common virus. It's basically the common herpes virus that more than 50% of the population has, and it is not harmful and does not cause illness to adults, but it can be devastating in fetuses. And the question here was, there was a positive donor and a negative mother, but the question is really whether or not that virus really could have been transmitted through the sperm, which goes through a thorough washing and freezing and processing process. And so while it is theoretically possible, and that was the plaintiff's argument, to transmit CMV via sperm, there's no reported case of it anywhere having happened, that this transmission could have happened through donor sperm. So that is, it was a first impression issue. And it really boiled down to an informed consent argument, which was that if you were going to use the sperm from a positive donor, you should have had a more fulsome informed consent discussion with the mother. But it leads you to really to a philosophical and metaphysical question, because if you use different sperm, then these two children would not exist. And so the idea that there were really 4 plaintiffs in the case, there were the 2 twins had their own claims, which were basically that they should never have existed. And then each of the parents had their own individual claims as well. So very fascinating causation and other issues on appeal. And if we can look at the next slide, I want to just highlight the damages, because I think it's important when we get these big verdicts to really dissect, what is being awarded, especially when it's a judge as opposed to a jury, but in any event. And it's not surprising to see that the majority of the damages here are for the surviving twin who did have a need for lifelong care, very severely disabled. And so a large part of it is the economic damages, which were the plaintiff's life care plan, which they put that forward and it was awarded. There's a couple of wins in the numbers, which is why I want to highlight this a little bit. And for the twin that did not survive, there was a claim for economic damages, which, as many of you know, and I've handled many stillbirth cases over the years, where you wind up getting a claim for lost earnings. And Dr. Crakes comes in and says that this infant, or fetus in some cases, where I've had that as well, would have earned $2 to $3 million over the course of their lifetime. And we are frequently in the position of having to argue, well, first of all, that's highly speculative. And second of all, there's really no economic, it doesn't make economic sense to award those kinds of lost earnings to a fetus or a baby that never worked and never had any living expenses. And so we've argued that unsuccessfully and had to present these kinds of claims to juries in the past. So what I love about Judge Taylor's decision is that he actually addresses that and rejects it and says exactly what I said, which is that it's very speculative and there's no practical purpose to awarding lost earnings to a twin that never, to a child that never lived. So I thought that was a significant win and something that we can use in future cases to argue both during mediations and during trials to other trial judges that there should not be lost earnings for infants like this. And so that's a big win. The other win, I think, on the damages side is the non-economic award of the $1 million to the devised twin, because again, that's something we can use now going forward to ground the damages of what is the non-economic damages for the loss of a child like that. And I've certainly had plaintiff counsel demand much higher than that number. So I actually think that in our world, it's not a bad number for the non-economic damages for the stillborn baby. And then the third thing that I take away from this as sort of a win for the defense is the fact that both parents argued for emotional distress damages, and it was awarded for mom because there was an idea that when a mother is receiving obstetrical care, that she has a direct duty, the OBs and the providers have direct duties to both the child and the mom. So that was a direct claim for emotional distress, but the bystander emotional distress claim from dad was rejected under the SQIO standard, which is a standard that I still, we've had a lot of success with that on summary judgment as well, where SQIO said in order to have a bystander emotional distress claim in a medical negligence situation, that the plaintiffs are limited to gross negligence and they have to prove gross negligence, and there was no evidence of that here in this case. So that was a significant win. Next slide. So then the other development that came since the Monroe Lynch decision, really, which is really just within the last 6 months or so, is the update on loss of filial consortium. Many of you may remember that in the pre-2016, there was no cause of action for tort cases for loss of parental or filial consortium, and that was under the Mandillo versus Board of Education rule, which was overruled in Campus versus Coleman, where a loss of parental consortium was recognized for tort cases in very limited circumstances. For minor children whose parents were injured, they could recover for the loss of that, the loss of their guidance and support until the age of 18. So it's a limited claim for loss of parental consortium. Since that decision, the courts have been split on whether that means that there also should be a loss of filial consortium. And so actually in the Hunt case, which is a products liability case regarding infant formula, the claim that having cow's milk as an ingredient in infant formula was leading to a higher rate of necrotizing enterocolitis or NEC. And so a baby that had passed away, the parents brought a cause of action, and it included a loss of filial consortium claim, which Judge Underhill in the district court recognized was not a decided issue under Connecticut law. And so he certified that up to the state Supreme Court, whether or not the state would recognize that as a cause of action, both for death and for living, for injured, as well as for death cases. Unfortunately, so I was excited to see that would be a decided issue. Perhaps maybe by the time we do this presentation next year, we'd have an answer to the question. But unfortunately, within the last couple of months, I learned that the defendants in the Abbott Labs case have moved to consolidate and transfer these cases. There are a variety of cases regarding the infant formula issue pending around the nation, and they have moved to consolidate it to a multi-district litigation, and all of the cases have been stayed, including the Supreme Court. The briefing on the Supreme Court decision has been stayed as well. So we're not really going to get that answer as quickly as I would have liked, but it's an interesting thing to think about going forward. Next slide. And then the last plaintiff's verdict that we're aware of from 2021 is this November verdict from Bridgeport before Judge Stewart. And this is a case where this is the damned if you do, damned if you don't kind of scenario for healthcare providers, because we get these cases all the time when more and more people are on anticoagulation medication for a variety of different reasons. And so I have so many cases where the medication isn't stopped before a procedure and then you have the bleeding complication. This is the opposite, where somebody was advised to go off the medication in advance of a minor procedure and allegedly that caused an embolic stroke. So, I mean, it's really a very hard thing for the providers to manage. When do you stop it? When don't you stop it? This was a 59-year-old man who'd been on Coumadin for 15 years. And the allegation really was that before it was a colorectal procedure that he was having done, a minor procedure, and that the surgeon should have checked with his neurologist who had prescribed the Coumadin before advising him to stop it 5 days before the procedure. You know, but again, if they hadn't advised him to stop it and he had a bleeding complication, there would have been a different type of case. The interesting thing about the verdict is that the economic damages were $750,000. He did have a stroke with permanent injuries, left-sided paralysis, and inability to walk. So the economics were fairly high. And then the non-economics were 2.45, which is about almost exactly 3 times the economics, which is not that shocking. And then the 1 million loss of spousal consortium. This was in person in the Bridgeport Superior Court, where there were a lot of space issues and mask wearing and everything else. So it was interesting from that perspective, and not a shocking number for what was involved, sadly for our jurisdiction. Next slide.
So we, you know, in addition to talking about, you know, the developments or interesting verdicts or trying to cover those, we also like to try to cover some other events or developments or things that we're looking out for in the area of medical malpractice litigation. And one of the things we wanted to touch upon is really just sort of an update that many of you probably already know some of this, but an update regarding the COVID immunity provisions that were contained within the governor's executive order. And the one in particular that we're going to focus on first is this one about providing immunity for acts and admissions taken in good faith while providing care services. And I'll highlight this phrase, in support of the state's COVID-19 response. And the reason I'm highlighting that is we have had actually some court decisions, at least one, that's addressed what this actually really means. And they've made it clear that the critical issue that they've, at least this court, focused on was the in support of the state's COVID-19 response. Next slide, please. In the Mills versus Hartford Healthcare case, it was a case is, I think, a case that the patient alleged a delay in diagnosis and treatment of a cardiac condition. She went to the hospital with a cardiac condition. This is during the time of COVID, right? Early on March 21st, she was admitted. There was concern whether the heart-related issues were COVID related or independent. So as per what was normally done during this period of time, they did a COVID test, and they needed to do a COVID test and isolate her. There weren't any rapid tests available or utilized at that point. So the test took some time to come back, and about 3 days. And on March 24th, the evening of March 24th, the test came back negative. So the following morning, she was scheduled to have a catheter procedure done. And before that catheterization procedure was done, she was found dead on the floor. They filed a lawsuit alleging a delay in diagnosis of her cardiac condition and a delay in treating the cardiac condition. The defendants filed a motion to dismiss, and they argued a lack of subject matter jurisdiction utilizing the immunity provisions of the executive order, 7V, I think it is, and argued that the immunity was provided for this period of COVID where treatment occurred in the context of the pandemic occurring. And what the court found, or at least in this decision held, was a sort of a split the baby type of decision. The first was that, yes, the immunity applied because you were acting in support of the state's COVID-19 response for the period of time from admission until you found out that there was a negative COVID test finding. And at that point, once you found that out, the immunity no longer applied. So they granted the motion to dismiss for all the activities that occurred up to March 24th at 7:40 p.m. and denied the motion to dismiss with anything that occurred thereafter. So, it sort of cuts both ways. It acknowledges that an immunity exists, but it also conversely acknowledges that there may be it may be viewed with specific limitations, and that language, I think, is probably going to be one of the ones that are going to be focused on in future matters where this likely will come up, and perhaps it has come up again. This is one that we just happen to be aware of, but it presents an interesting view and something that at least giving us some insight into what the thought processes might be. Next slide, please. And the other area, and this is directly pandemic or COVID related, is getting some insight into how the statute of limitations are going to be impacted or are impacted by the governor's executive order, which stayed the statute of limitations for a period of, I think, about 346 days total. And what we know from at least one, and I'm aware of, I think, two now decisions that address how to apply that tolling of the statute of limitations to a real life situation. Next slide, please. And what happened in the Kapua versus Hill matter, it was a decision by Judge Sicilian in Hartford, and it was in response to a motion to strike and the motion to strike was really addressed that the plaintiff had filed their action 3 months after, in a perfect world, without COVID, the statute would have expired. But because the executive order was in place, staying the statute for a period of 346 days, the court held in its denial of the motion to strike that the plaintiff had the same amount of time that they would have had at the time of the entry of the tolling tacked on to the end of the entry. So in other words, in this particular case, on March 1st, March 19th, 2020, there was still 329 days left in the statute of limitations for the plaintiff in this particular case. That stopped and was basically stagnant and restarted on March 1st, 2021. So they essentially added the 329 at the end of that period and gave them an additional time and denied the motion to strike and proceeded. I think this is more likely, next slide please, more likely the way that this issue is going to be addressed on a going forward basis, just because I guess it makes some logical sense. But the problem with it is we have to bear in mind that what this has done is impacted those cases where the claims either were just occurring or had not yet occurred until the onset of this tolling period. And that means that, our ordinary world of 2 years and potentially 2 years and 90 days may ultimately potentially get extended to 2 years, 90 days plus the 346 that was told. So, we just have to do a lot of math, but be wary of it. And I think, maybe part of the lesson here is that, getting a decision in favor of dismissing or getting summary judgment or otherwise in a statute of limitations case in Connecticut is becoming, it was always very hard, and it's becoming increasingly harder to get. And the court is finding, a lot of ways to avoid doing that, for whatever reasons. And this next, I just want to touch on very briefly, but there was a Supreme Court decision a month or so ago that addressed the statute of limitations issue from a different perspective, but it highlights what I just said, which is that it's becoming increasingly more difficult. And in this Peak case, it really was about when a statute of limitations begins to run. It says, or the statute says, when the injury occurs or you reasonably know that you have an actionable harm. Meaning, in the old view, maybe it used to be, or one would think that if an injury occurred to you and it was blatant, obvious, clear, that you would presumably you would know that that was an actionable harm, whether or not you pursued it or otherwise. It was more the latent ones that we thought would be the discoverable harm. So those things where maybe a cancer wasn't diagnosed on a film, and the patient would never have any idea of that because they're not physicians, and then it was discovered 6 months later by a different radiologist that there was cancer there and it had some impact. That would be a situation where they couldn't reasonably have discovered it. So there was always the argument that you could say it was blatant, therefore it is reasonably discovered. The only thing so the trial court here did grant summary judgment on the grounds that it was beyond the statute, but the appellate court reversed, and then the Supreme Court ultimately affirmed the appellate court, and they basically said, look, the issue of actionable harm and knowledge of when the actionable harm occurred is really an issue of fact, and we're not going to decide that based on the law. So I'm a long-winded way of saying, the point being, it's very difficult, and now even more so difficult, to get summary judgment summary judgment on a statute of limitations issue. Next slide, please. And another thing, this is something that's recently come up, and it obviously is not yet a law, but it is concerning. And I think recently had a public hearing before the Judiciary Committee this past week. And it's a proposed House Bill 5235, which is really addressing a change in the offer of compromise statute. So the offer of compromise in Connecticut, in a nutshell, and there are distinctions between those that involve healthcare provider cases and others, but the general gist of it is plaintiffs can file an offer of compromise, an offer to settle the case with the court, formal offer, and the defense can either accept it or they can decline to accept it. If it's filed, as the current law stands now, if it's filed within 118 months, from the date of the filing of the complaint, and the plaintiff recovers an amount equal to that offer of compromise or greater, they are entitled to get interest at 8% per annum back to the date of the filing of the complaint. If they file it beyond the 18 months, then they get 8% interest from the date of filing the offer of compromise. So there's a distinction between that, and it can be meaningful depending on what the dollar values of the judgment are. But what this bill proposes to do creates two problems. One, it proposes to remove the distinction between those filed within 18 months of the complaint and those filed after, and essentially removes that timeline entirely and says it doesn't matter when you file it. You could file it theoretically on the eve of trial. If you get a verdict in excess or equal to that, you're going to get 8% back to when the cause of the action began, and that's the second problem. There's no definition clarifying what the cause of the action, if that's the subject of, the cause of action, which is the subject of the civil action, what that means. Does it mean when the complaint's filed, or does it mean when the injury occurs? And as you can imagine, if it means when the injury occurs, now we're tacking on an additional potentially 2-3 years worth of interest, maybe more, onto what otherwise would have been a more definable period of time for an offer of compromise. So we're talking exponentially larger amounts of interest So this is a problematic bill on many fronts, and it's certainly prejudicial to the defense side of it for sure. And it was referred to the Judiciary Committee, I think, in late February. It was before in a public hearing last week. I understand that there were 15 written submissions in the public hearing, and 14 of those submissions were against it. The judiciary, as it normally does, or the judicial branch usually takes an independent, a non-committal view, but they did question what the meaning of cause of action, which is the subject of the civil action, means. So that's interesting to note. There was no action yet taken on it, and it's not clear whether the bill will be killed or it's going to be referred out of the judiciary. The hope is that it's killed. I know that there were a number of organizations and some law firms that had submitted written testimony, which were excellent and in opposition to it. And I think more to come, but this just raises another issue, and it ties into the statute of limitations extension, because COVID added at least 346 days, but it could have added more. Because cases haven't moved along as quickly as possible. So where it might have taken 3 years to get to trial, it could take 5. And if it takes 5, that's 5 years worth of interest, potentially more. I think we tried to calculate it out. Could you get up to maybe 7 or 8 years worth of interest? And that can be exponentially larger than anything that we would have previously imagined. Next slide.
Thanks, Kevin. Yeah, so from the potentially really, really bad news, which we hope that bill never has any legs, now to some potential good news. On the good faith certificate, there were some really good decisions this year. This was a 7-0 unanimous decision from the Connecticut Supreme Court, basically saying that the plaintiff's lawyer who failed to include the credentials of their similar healthcare provider in the attached letter, in the good faith certificate, then they could not refile the action under the accidental failure of suit statute, which allows for things to be refiled if it was a mere mistake or inadvertence. And here the court found that this was gross negligence. It's still a very factual test, but the lawyer, there was an admitted failure to even have read the controlling appellate court case law, which had been decided more than 6 years before the lawsuit was filed. So that the idea that you didn't even know about the decision, it was available to you to know about it, and that this was a lawyer who actually did file a fair number of medical malpractice cases, so they should have known, was a very helpful decision for us from defendant's perspective. And one of the things that the court said too is that the adequacy of these similar healthcare provider opinion letters is one of the most frequently litigated pretrial issues in medical malpractice cases. So to not know it was gross negligence, and that's really helpful for us going forward. Next slide. There's also another good faith certificate decision out there regarding, whether or not an endodontist is a similar healthcare provider to a general dentist. So just highlighting, this is something, the decision was decided by the appellate court. A supplemental affidavit after the fact does not fix the deficiencies in the letter. So this was dismissed and affirmed, but it's pending before the Connecticut Supreme Court now too. So we'll see what the Supreme Court says about it, but just bearing in mind that this is still a really important issue to look at those physician letters really carefully and make sure that the credentials are described and that the healthcare provider really is similar, because this is something that we have in our toolkit to really try to get rid of some of these cases. Next slide. And then the last thing, I know it's 10 o'clock and everybody needs to get on their way. The snow has started to fall, at least here in New Haven. But I wanted to highlight that everyone is probably already aware that Connecticut has adopted standard medical malpractice discovery requests effective January 1st, 2022. There are forms in the practice book. This could be its own 45-minute presentation, so I'm not going to belabor the point. I've talked about it quite a bit, and many of you probably have heard me already. There's some good stuff in here, which is getting standard compliance from the plaintiffs is fantastic. They can't object to 53 interrogatories and 20 RFPs, which gives us all the standard stuff. No more objecting, no more fighting. That's really helpful in some respects. And we also do have the ability to supplement as well. But the bad news is that there is an increase in a defendant's obligations to produce, which is really troubling on the document production side of things. And that's something that I've talked and thought a lot about. There's very voluminous document requests, and I think there was a lack of appreciation of how difficult it is and how many different places you need to check within a health system. I think there was a misconception that, especially with electronic medical records, all you do is push a button and you can get all of the records with respect to a particular patient, and that's just not as easy as it sounds. So a couple of things just to highlight that the document request asks for all of the records regarding a particular patient, and it doesn't limit it to the care at issue in the complaint or to a particular time period. So bear that in mind for patients who have a lot of experience or have had a lot of admissions at a particular institution. And the lawsuit only concerns the last one, for instance. How far back in time do we really need to go? Is it reasonable to go all the way back to the beginning of time when there is some limited issue that only involves the last admission? And again, we can't object, but we can answer these things in a careful way, in my opinion, so that you can really explain what you're doing so that it's not unreasonable and unduly burdensome, because to go back to the beginning of time for a particular patient might be really burdensome, particularly where it also asks as a standard request for audio recordings of radiology reviews, drafts of pathology reports, requisition forms, lots of things that may or may not be in the EMR, may be housed in a particularly different EMR system or in a different filing system. And it is a lot of work for people to go to each different department and figure out what paper or other filing systems they might have. So this could be very time consuming to go find and produce all these different things when there's not even really a relevance to the care at issue. If the pathology or the radiology is not the crux of the case, then why are we running around to get all of these things? So I think it's important to craft responses that make it clear what's being produced and reserving the right to supplement, because the other thing is that, especially for big healthcare institutions, you never know when you're going to have that meeting with an individual provider a year or two into the case, and suddenly they pull out their shadow file, or they tell you about some text messages they had with the patient, and you didn't know that until that moment in time. And it would be really burdensome to try to run around and interview everybody that touched the patient at the very outset in order to comply with the initial discovery in the first 60 days of the lawsuit. So this is going to be an ongoing struggle to figure out exactly what are our obligations and how far can we push this. While we can't object, as I said, I think we do have to put some limits on the responses, as opposed to saying this is everything, because it's really hard to verify that it's everything. Next slide. So, and the takeaway is just that with these new production requests, it's like we're not in Kansas anymore. So with that, that's the end of our program. Unless there are any questions, I can give you the final CLE code, which is 1716. And Kevin and I are available to answer any questions. I'm sure Maggie will be too, but we do appreciate your participating, and we hope to have a further discussion about the medical liability and keep the conversation going. Thanks so much.
Thank you all.